Question 1. From a practical standpoint, Maria, a 63-year-old postmenopausal woman, recently underwent a DA scan of her lumbar spine. The scan revealed a T-score of -2.7, indicating osteoporosis. However, upon closer examination of the images, it was noted that the L vertebra appeared sclerotic, likely due to degenerative changes. The technician included all vertebrae from all in the region of interest. Roy. Analysis. What is the most appropriate course of action regarding the interpretation of Maria's results? A. Retain L in the analysis because excluding data might affect diagnosis of osteoporosis. B. Exclude L and base BMD interpretation on L, provided at least 2 vertebrae remain for analysis. C. Repeat the scan using different scanning mode to compensate for artifact. D. Retain all vertebrae and rely on the T-score provided by the software. Answer. Correct answer. B. Explanation. According to the IST Official Positions 2023, an ASRT bone densitometry curriculum, when vertebrae exhibit structural anomalies such as sclerosis due to degenerative changes, they must be excluded from analysis if they differ by more than 1.0 SD from adjacent vertebrae, including such vertebrae skews BMD results leading to inaccurate T-scores and misclassification. Minimum requirement for interpretation is 2 evaluable vertebrae. Retaining L would overestimate BMD and misinform treatment plans. Rescanning option C is unnecessary unless multiple vertebrae are affected. Trusting unadjusted software output option D violates quality assurance protocols. Question 2. The underlying principle of dual energy X-ray absorptiometry (DSA) hinges on the attenuation properties of different tissues. What best explains the reason a DSA uses 2 energy levels in its scans? A. To improve image resolution and reduce scan time. B. To enhance visualization of soft tissue structures. C. To differentiate bone from soft tissue by evaluating their differential attenuation at 2 X-ray energies. D. To estimate calcium content directly. Answer. Correct answer. C. Explanation. DSA employs 2 distinct X-ray energy levels to exploit the fact that bone and soft tissue attenuate X-rays differently depending on the energy used. This dual energy principle allows the system to mathematically separate bone mineral content from surrounding soft tissue, ensuring accurate BMD measurement. This is fundamental DSA as outlined in the ASRT curriculum under Basic Principles of Attenuation. Image resolution and scan time A are affected by beam type and mode, not dual energy. DSA does not focus on soft tissue structures. B. And it does not measure calcium content directly. D. Question 3. Considering the evidence, Mr. Anderson, a 70-year-old man with a history of chronic corticosteroid use and a recent DSA scan showing a T-score of -1.8 at the femoral neck, is classified as having osteopenia. However, he recently sustained a low-trauma vertebral compression fracture confirmed on radiography. What is the most appropriate clinical interpretation based on current guidelines? A. Maintain osteopenia diagnosis as BMD is the only diagnostic criterion. B. Reclassify Mr. Anderson as osteoporotic due to the presence of fragility fracture. C. Repeat the DSA scan to confirm diagnosis. D. Categorize as severe osteoporosis due to his medication history. Answer. Correct answer. B. Explanation. According to the World Health Organization, WHO, and supported by ASRT guidelines, a fragility fracture in an individual over 50, especially with osteopenic EMD, justifies the diagnosis of clinical osteoporosis even if the T-score is above -2.5. The presence of vertebral fractures indicates compromised bone strength. BMD alone is not the sole determinant. History D does not automatically reclassify him as severe osteoporosis unless additional fractures are present. Repeating the scan C offers no new diagnostic value in light of radiographic evidence. Question 4. Among the various types of radiation safety practices, one of the most essential principles in bone densitometry is to ensure minimal exposure to both patients and operators. Which principle best supports this approach to safety in clinical practice? A. Principle of inverse square law. B. ALARA principle. As low as reasonably achievable. C. Thermoluminescent dosimetry monitoring. D. Use of lead aprons for all patients. Answer. Correct answer B. Explanation. The ALARA principle, rooted in the U.S. Nuclear Regulatory Command (NRC) and emphasized by ASRT's radiation safety guidelines, promotes minimizing radiation exposure by optimizing shielding, collimation, and technique factors. While lead aprons D are useful in general radiography, their use in DSA is minimal due to low-dose exposure. Inverse square law A is principle of radiation physics, not direct safety guideline. Thermoluminescent dosimeters C monitor exposure but do not reduce it. Question 5. Through the lens of patient positioning and reproducibility in DSA, incorrect limb rotation or alignment can significantly alter BMD readings. Which of the following best illustrates the consequence of incorrect internal rotation of the femur during a hip scan? A. Overestimation of BMD due to cortical thickening. B. Underestimation of BMD due to inclusion of greater trochanter. C. Increased precision due to more reproducible anatomy. D. No significant impact as software compensates for positioning. Answer. Correct answer A. Explanation. Incorrect positioning, such as insufficient internal rotation of the femur, often excludes the femoral neck and emphasizes the cortex of the lesser trochanter, artificially increasing BMD values. This is covered in detail in the ASRT's patient positioning protocols. Proper internal rotation 1525 deg aligns the femoral neck perpendicular to the X-ray beam, ensuring consistent row placement. Software compensate for anatomical misalignment. D. Therefore, careful patient positioning is critical for reproducibility and diagnostic accuracy. Question 6. With respect to the role of parathyroid hormone pH in bone metabolism, pH has both catabolic and anabolic effects depending on its mode of action. Which of the following best describes the physiological impact of continuous pH elevation on bone? A. Increases bone formation by stimulating osteoblast proliferation. B. Stimulates osteoclast activity leading to increased bone resorption. C. Reduces bone turnover by inhibiting both osteoclasts and osteoblasts. D. Has no direct effect on bone, acts solely on kidneys and intestines. Answer. Correct answer B. Explanation. Continuous elevation of pH, as seen in primary hyperparathyroidism, stimulates osteoclast activity via a Rankel pathway, leading to increased bone resorption. However, intermittent administration, e.g. teriparatide, can have an anabolic effect. The dual effect is covered under bone physiology and hormonal regulation in the ASRT curricula. pH acts indirectly on osteoblasts, stimulate osteoclasts. It also promotes calcium reabsorption in the kidney and absorption in the gut via vitamin D, but its direct skeletal effects are pivotal in metabolic bone disease. Question 7. During the process of quality assurance testing on a DA system, the technician notices a gradual upward drift in BMD measurements on the spine phantom, although the hardware and environment appear stable. Which of the following is the most appropriate next step? A. Ignore the trend. Phantom drift is clinically insignificant. B. Recalibrate the system using manufacturer's instructions. C. Report to the supervising radiologist for repeat phantom testing. D. Continue using the system and compare with future patient scans. Answer. Correct answer B. Explanation. Upward drift in phantom BMD indicates potential calibration instability. According to ISCT and ASRT quality assurance protocols, this requires immediate recalibration or maintenance to prevent misdiagnosis in patient scans. Continuous use without correction. D. Is inappropriate. Reporting to a supervisor. C. May be part of the chain, but actionable response is recalibration. Phantom drift, subtle, must be corrected to maintain diagnostic integrity. Question 8. Based on the information, which of the following bone cell types is primarily responsible for detecting mechanical stress and signaling bone remodeling processes? A. Osteoblasts. B. Osteoclasts. C. Osteocytes. D. Chondrocytes. Answer. Correct answer C. Explanation. Osteocytes, derived from trapped osteoblasts within the bone matrix, act as mechanosensors, detecting strain and initiating remodeling signals through the release of factors such as sclerostin. This distinguishes them from osteoclasts, bone resorption, osteoblasts, bone formation, and chondrocytes, which are not involved in bone remodeling. This function is outlined in the microscopic bone structure section of the curriculum. Question 9. The prevailing attitude toward pediatric bone densitometry emphasizes unique challenges and ethical concerns in interpretation. Which of the following best reflects the reason why T-scores should not be used in pediatric populations? A. Children have higher cortical density, which skews T-scores. B. T-scores compare to young adult mean and do not reflect age-matched norms. C. Takese is contraindicated in individuals under 18. D. T-scores are only applicable for spinal scans, not pediatric scans. Answer. Correct answer, B. Explanation. T-scores compare an individual's BMD to 30-year-old reference population, making them inappropriate for growing children. Instead, Z-scores, age, sex, and ethnicity matched, are used. This is emphasized in IST pediatric positions and the ASRT curriculum. Option A is not justification for T-score exclusion. DKSA is safe in pediatrics. C, with justification. T-scores are not limited by anatomical site. D, but by population relevance. Question 10. While examining a DIA report, the technician notices the presence of an abdominal aortic calcification overlaying the lumbar vertebrae. Which of the following best describes the impact of this artifact on BMD measurement? A. It causes underestimation of lumbar spine BMD. B. It has no impact as DSA filters out vascular structures. C. It causes overestimation of lumbar spine BMD. D. It only affects vertebral morphometry, not EA. Answer. Correct answer, C. Explanation. Abdominal aortic calcification, being dense, attenuates X-rays similar to bone, leading to artificially elevated BMD values in the lumbar spine. This is a known artifact covered under DSA interpretation and artifact recognition in the ASRT curriculum. It can result in diagnostic misclassification if not properly identified and excluded from the analysis. The DSA system cannot filter vascular structures. B, and it directly affects BMD values, not just morphometry. Question 11. When considering bone metabolism, which of the following hormones is primarily involved in regulating bone resorption by activating osteoclasts? A. Estrogen. B. Parathyroid hormone. C. Vitamin D. D. Testosterone. Answer. Correct answer. B. Parathyroid hormone. Explanation. Parathyroid hormone, PH, is a major regulator of bone resorption. It increases osteoclast activity, leading to the breakdown of bone and release of calcium into the bloodstream. In contrast, estrogen and testosterone primarily help maintain bone density by inhibiting bone resorption. Vitamin D plays a role in calcium absorption and bone health, but does not directly regulate osteoclast. Question 12. Given the circumstances of a DA score, which anatomical site is typically measured for assessing bone density in cases of suspected osteoporosis in a postmenopausal female? A. Pelvis. B. Distal radius. C. Lumbar spine. D. Proximal tibia. Answer. Correct answer. C. Lumbar spine. Explanation. The lumbar spine is one of the standard anatomical sites for DSA measurement in individuals suspected of osteoporosis. It is particularly relevant for postmenopausal women as they are at an increased risk for osteoporosis, and the spine is a common site for fractures related to this condition. While other sites like the distal radius and pelvis can also be assessed, the spine is prioritized due to its susceptibility to osteoporosis-related fractures. Question 13. From the perspective of DAK technology, what is the main advantage of using a fan beam over a pencil beam system in bone densitometry? A. Faster scan time. B. Higher resolution images. C. Reduced radiation exposure. D. Improved accuracy in soft tissue differentiation. Answer. Correct answer. A. Faster scan time. Explanation. Fan beam systems allow for a broader scanning area compared to pencil beam systems, which enables faster acquisition of images. This reduces the overall scan time for the patient, making the process more efficient. Pencil beam systems, while more accurate in terms of image resolution, are slower because they scan the area point by point. Both systems have their uses, but the fan beam system's speed is advantage. Question 14. What would happen if a DA scan is performed without proper positioning of the patient's body, especially in relation to the lumbar spine? A. The BMD results will be skewed due to improper scanning angles. B. The scan will be completed but without meaningful data for clinical evaluation. C. The results will be accurate as long as the patient is in the correct general area. D. The image quality will improve but may show exaggerated results. Answer. Correct answer A. The BMD results will be skewed due to improper scanning angles. Explanation. Proper patient positioning is critical in DSA scans, particularly for the lumbar spine, as inaccurate positioning can lead to erroneous BMD measurements. Improper angles can result in a skewed interpretation of bone density, potentially misdiagnosing conditions like osteoporosis or misguiding treatment decisions. Clear positioning instructions. Use of positioning aids are essential for accurate and reproducible results. Question 15. Considering the evidence of bone densitometry, how does the use of dual-energy X-ray absorptiometry (DSA) compare to quantitative ultrasound for bone density measurement? A. DSA is more cost-effective than QUS. B. DSA provides more detailed volumetric bone density measurements than QUS. C. QUS is more commonly used for clinical diagnosis of osteoporosis compared to DSA. D. DSA is better for assessing trabecular bone than QUS. Answer. Correct answer. Both DSA provides more detailed volumetric bone density measurements than QUS. Explanation. DSA is the gold standard for assessing bone mineral density, BMD, providing detailed, reliable data about bone density at various anatomical sites. It measures areal BMD, which can be used to calculate the risk of fractures. QUS, while less expensive and portable, does not offer the same level of detail, especially volumetric MD measurements, and is not as reliable for diagnosing osteoporosis or predicting fractures. Question 16. Which of the following best describes the role of osteoblasts in bone remodeling? A. They break down bone tissue to release calcium. B. They regulate the activity of osteoclasts. C. They produce the matrix that forms new bone. D. They maintain the structural integrity of bone after remodeling. Answer. Correct answer. C. They produce the matrix that forms new bone. Explanation. Osteoblasts are responsible for producing new bone matrix during the bone remodeling process. They secrete collagen and other proteins that make up the bone extracellular matrix, which then mineralizes to form new bone. Osteoclasts, on the other hand, are involved in the resorption of old bone tissue. Osteoblasts play a critical role in bone formation and repair. Question 17. What factors are primarily considered when determining the need for a DSA scan in a patient with osteoporosis? A. Patient's age and gender only. B. The baseline BMD and rate of bone loss. C. Whether the patient has any history of fractures. D. The number of medications the patient is taking. Answer. Correct answer. B. The baseline BMD and rate of bone loss. Explanation. Follow a DSA. Scans are often based on a patient's baseline BMD and the rate of bone loss over time. If the patient's BMD decreases significantly between scans, it may indicate the need for more aggressive intervention, while age, gender, and fracture history are important in determining a patient's overall risk. The rate of bone loss is the most significant factor in deciding when a follow-up scan is necessary. Question 18. In the context of radiation safety, which of the following guidelines is most commonly recommended for minimizing patient radiation exposure during bone densitometry procedures? A. Limiting scan area to the necessary region only. B. Increasing the radiation dose to improve image clarity. C. Using the highest possible energy settings to reduce scan time. D. Encouraging patients to undergo multiple scans at once for convenience. Answer. Correct answer A. Limiting scan area to the necessary region only. Explanation. The ALARA, as low as reasonably achievable, principle is fundamental to radiation safety. By limiting the scan area to only the necessary region, the radiation dose is minimized, which reduces the patient's exposure. Increasing the radiation dose or using unnecessarily high energy settings would violate this principle. Multiple scans at once, unless necessary for reasons, should be avoided as they increase the patient's overall exposure. Question 19. During the process of analyzing a DU report, A t-score of -2.5 indicates A. Normal bone density, B. Osteopenia or low bone density, C. Osteoporosis or high fracture risk, D. A healthy individual with no risk of bone fractures. Answer. Correct answer, C. Osteoporosis or high fracture risk. Explanation. A t-score of -2.5 or lower is diagnostic for osteoporosis according to the World Health Organization, WHO classification. It indicates that bone mineral density is significantly below the average peak bone mass for a young adult, which increases the risk of fractures. Osteopenia, which is a less severe condition, is indicated by a t-score between -1.0 and -2.5. Question 20. What is the primary reason for performing vertebral fracture assessment (VFA) alongside a DA scan? A. To assess total body bone density, B. To directly measure bone turnover, C. To detect vertebral fractures or deformities, D. To estimate the patient's age and gender. Answer. Correct answer, C. To detect vertebral fractures or deformities. Explanation. Vertebral fracture assessment (VFA) is typically performed alongside DSA scans to identify vertebral fractures, which are common in individuals with osteoporosis. VFA helps in detecting both existing fractures and subtle vertebral deformities that might not be apparent clinically but can indicate increased fracture risk. It is not used for measuring turnover or estimating age and gender. Question 21. In the context of macroscopic and microscopic bone structure, Dr. Morris is analyzing a bone biopsy specimen from a 68-year-old patient who presents with chronic bone pain, skeletal deformities, and an abnormal increase in bone size. Microscopic examination of the specimen reveals a mixture of disorganized woven bone with areas of normal lamellar bone. A distinctive mosaic pattern, which indicates accelerated but irregular remodeling, is evident. Increased vascularity in the bone tissue is also observed, suggesting an active remodeling process. These features are suspicious for a metabolic bone condition characterized by such histologic changes. Which of the following conditions most closely corresponds to these histologic findings? A. Osteomalacia, B. Osteoporosis, C. Rickets, D. Pagets disease. Answer. Correct answer, D. Explanation. Pagets disease is characterized by an abnormal bone remodeling cycle with excessive osteoclastic resorption followed by disorganized osteoblastic bone formation. This results in the histologic appearance of both woven and lamellar bone arranged in a characteristic mosaic pattern along with increased vascularity. In contrast, osteomalacia is primarily a defect in bone mineralization leading to soft, while osteoporosis B involves a reduction in bone mass without the disorganized architecture of rickets. C affects children, leading to defective mineralization of the growth plate. These distinctions are well outlined in the ASRT bone densitometry curriculum and various bone pathology guidelines. Question 22. Throughout the course of growth and bone remodeling MS, Walters, a 16-year-old competitive soccer player, presents with persistent knee pain and localized swelling near the distal femoral region. Radiographic imaging suggests a minor stress reaction at the physeal plate area. Given that the epiphyseal plates are regions of active bone growth, any premature closure or abnormal remodeling here could lead to significant limb length discrepancy and altered joint mechanics. MS. Walters' coach and physician are concerned that repeated microtrauma may accelerate premature fusion of the growth plate, thereby affecting her athletic performance and long-term joint function. Which of the following potential complications is most likely if premature fusion of the epiphyseal growth plate occurs in this region? A. Decreased risk of stress fractures in the adjacent metaphyseal region. B. Angular deformity due to asymmetrical growth. C. Enhanced bone strength from accelerated mineral deposition. D. Uniform limb growth with negligible clinical impact. Answer. Correct answer, B. Explanation. Premature fusion of an epiphyseal plate in a growing individual can lead to an angular deformity due to asymmetrical growth where one side of the bone ceases growing earlier than the other. This disrupts the normal alignment, leading to possible deformity and joint dysfunction. Option A is incorrect because premature fusion does not reduce stress fracture risk. It rather altered biomechanics may increase it. Option C misinterprets accelerated growth, which is not equivalent to improved strength. Option D is clearly not applicable as premature closure has significant clinical implications. This concept is emphasized in the bone growth and development section of the curriculum. Question 23. Based on the information, Ms. Davis, a 65-year-old woman with suspected osteoporosis, underwent a DA scan that revealed a borderline T-score at the femoral neck. However, the scan image displays an artifact likely due to the presence of an orthopedic implant in the hippie region. The artifact has made one part of the region of interest, ROI, appear much denser than the surrounding bone tissue, thus potentially misleading the BMD measurement. Ms. Davis' treating physician is now questioning whether the artifact has significantly affected the results and what the best practice for ROI analysis is under these circumstances. Which of the following is the most appropriate management strategy in this case? A. Include the entire ROI, since modern DSA software automatically corrects for artifacts. B. Exclude the artifact-affected area from the ROI and recalculate the BMD based on the unaffected regions. C. Discard the scan entirely and classify the patient as osteoporotic based on age and clinical risk factors. D. Increase the scan exposure settings to overcome the artifact interference. Answer. Correct answer, B. Explanation. Artifacts such as orthopedic implants can artificially elevate BMD measurements by increasing local X-ray attenuation. The current ASRT guidelines and its official positions advise that any region affected by artifacts should be excluded from the analysis to avoid misdiagnosis. Modern DSA systems do not automatically correct such focal artifacts, making option unacceptable, and adjusting settings option D is not a recommended strategy. Discarding the scan entirely, option C, is also not advised since parts of the scan remain valid. Recalculating BMD but excluding the artifact ensures accurate assessment. Question 24. Under the assumption that a patient's radiation exposure should be as low as possible, Mr. Brown, 45-year-old undergoing routine bone densitometry evaluation, is concerned about his cumulative X-ray dose. The technologist explains that even though DSA scans involve low radiation, adhering to strict radiation safety principles is paramount. Mr. Brown learns that the radiation dose is minimized by not only using low-dose X-rays, but also by applying best practices in patient shielding, collimation, and scan area limitation. Which of the following fundamental radiation safety principles is most applicable to bone densitometry? A. Continuous X-ray beam exposure. B. ALARA. As low as reasonably achievable. C. Maximizing scan time to ensure clarity. D. Utilizing high radiation doses in short sequences. Answer. Correct answer, B. Explanation. The ALARA principle is the cornerstone of radiation safety, emphasizing that radiation exposure should be kept as low as reasonably achievable while still achieving the desired diagnostic quality. This principle is widely adopted by regulatory agencies and is a key part of the ASRT bone densitometry curriculum. Options A, C, and D run contrary to the fundamental goal of minimizing radiation exposure and are not acceptable practices for protecting both patients and operators. Question 25. When considering detector systems in DSA, Dr. Lopez has recently upgraded his clinic's bone densitometry equipment from pencil beam to fan beam configuration. In detailed review of the technical specifications, he notices that while the fan beam DSA system improves patient throughput and scanning efficiency, some differences in measurement characteristics are notable. The discussion revolves around how the change in technology might affect interpretation and accuracy of the scans, particularly regarding soft tissue correction and BMD precision. Which of the following statements best summarizes the advantages of using fan beam system over pencil beam system? A. Fan beam systems are inherently less accurate in measuring bone density than pencil beam systems. B. Fan beam systems enable faster scan times while maintaining acceptable precision with comparable quality assurance protocols. C. Pencil beam systems provide quicker results, making them preferable for busy clinical settings. D. Fan beam systems are more costly with no discernible benefits over pencil beam systems. Answer. Correct answer, B. Explanation. Fan beam DSA Systems are designed to cover a broader area, which results in faster scan times and higher patient throughput without compromising measurement precision when proper quality assurance protocols are in place. While pencil beam systems traditionally offer slightly higher resolution, the modern fan beam systems have been optimized to maintain high accuracy in BMD assessments. Options A and C are not supported by current evidence, and option D incorrectly dismisses the advantages of improved efficiency and workflow. Question 26. By comparing patient positioning protocols, MS Rivera, a 58-year-old woman scheduled for a HAP-ESA scan, is counseled by the technologist on the importance of consistent positioning. During her scan, precise alignment of the femur is crucial for accurate region of interest ROI placement, ensuring that comparable anatomical landmarks are captured. Improper placement may result in measurement errors and misinterpretation of the BM, potentially affecting both diagnosis and treatment decisions. The technologist demonstrates the use of positioning aids and clear alignment protocols to optimize the scan quality. Which of the following best describes the importance of correct ROI placement in HIP DSA scans? A. It ensures that the scan covers more soft tissue for better calibration. B. It minimizes the inclusion of artifacts and non-representative areas, thereby optimizing the accuracy of a BMD measurement. C. It reduces the overall scan time by narrowing the field of view. D. It automatically adjusts the T-score based on patient age. Answer. Correct answer. B. Explanation. Correct ROI placement is vital for obtaining accurate and reproducible BMD measurements. Ensuring that only the appropriate bone regions are analyzed minimizes the potential impact of artifacts, extraneous soft tissue, or anatomic variants that could skew the results. The ASRT curriculum emphasizes that standardized positioning and ROI placement protocols reduce measurement errors and variability. Options A, C, and D do not address the clinical necessity of precise anatomical targeting. Question 27. In light of recent developments in nutritional influences on bone health, Mr. Franklin, a 50-year-old man with low vitamin D levels, is evaluated as part of a bone densitometry program. He has recently started vitamin D supplementation in hopes of improving his bone health. His clinician explains that vitamin D is crucial for calcium absorption and overall bone metabolism, but that the biochemical and densitometric may take time to manifest. Mr. Franklin is informed that improvements in bone mineral density, BMD, might not be immediately visible on subsequent DSA scans. Which of the following statements best describes the role of vitamin D in bone health with respect to DSA measurements? A. Vitamin D directly increases areal BMD by altering the DSA machine calibration. B. Vitamin D primarily facilitates calcium absorption, which indirectly supports bone mineralization over time. C. Vitamin D supplementation immediately alters bone architecture, making early SA changes evident. D. Vitamin D has no measurable effect on bone density, as seen on DSA scans. Answer. Correct answer. B. Explanation. Vitamin D is essential for effective calcium absorption in the gut, which in turn supports bone mineralization and overall skeletal health. Its role is indirect by ensuring that sufficient calcium is available for the mineralization process. Vitamin D helps maintain or gradually improve bone density. The changes in BMD detected by ESA scans occur over a longer period and are not immediately following supplementation. Options A, C, and D misinterpret the physiological role of vitamin D as well as the time course in which clinical improvements are observed. Question 20. Through careful analysis of serial bone densitometry studies, Dr. Pommer is tracking a 70-year-old patient's BMD over several years. The concept of least significant change, LSE, is crucial in determining whether observed changes in BMD exceed the inherent measurement variability of the DSA instrument. This concept is particularly important when evaluating the efficacy of therapeutic interventions in patients with metabolic disease. Failure to account for LSE may lead to misinterpretation of minor fluctuations as clinically significant changes. Which of the following best defines the concept of least significant change LSE in serial DSA measurements? A. The minimum change in BMD required to alter the patient's T-score category. B. The statistical threshold that distinguishes true biological change from measurement error in BMD over time. C. The difference in BMD between two anatomical sites during single scan. D. The amount of bone density variation due solely to patient positioning errors. Answer. Correct answer. B. Explanation. The least significant change LSE is defined as the smallest change in BMD that can be confidently distinguished from random measurement error based on the precision of the DSA system. It is a statistical threshold used in serial densitometry to help clinicians decide whether an observed change in BMD is significant enough to indicate a true biological effect rather than normal variability. Concept is thoroughly reviewed in the serial bone densitometry sections of the curriculum. Options A, C, and D do not capture this statistical and clinically relevant measure. Question 29. Considering the evidence regarding pediatric bone densitometry, Dr. Grant is evaluating a 12-year-old boy who presents with a suspected bone density abnormality. In pediatric patients, the use of T-scores, which compare an individual's BMD, a young adult reference is not appropriate because it fails to account for age-related changes in bone mass. Instead, Z-scores, which compare the patient's BMD to age, sex, and ethnicity-matched norms are recommended for assessing bone health in children and adolescents. Which of the following statements best explains why T-scores are not recommended for use in pediatric bone densitometry? A. T-scores overestimate bone density in rapidly growing children due to their dynamic skeletal changes. B. T-scores compare patients' BMD to young, healthy adult reference, making them inappropriate for evaluating the growing skeleton. C. T-scores are designed specifically for assessing soft tissue composition in pediatric populations. D. T-scores have been replaced by ultrasound measurements in children. Answer. Correct answer. B. Explanation. T-scores are calculated by comparing a patient's bone mineral density, BMD, to the average PEMD of young healthy adult, typically around age 30. Because children and adolescents are still growing, their BMD naturally changes over time, and using T-score can lead to misinterpretation of bone health. Instead, Z-scores, which compare BMD to age, sex, and ethnicity-adjusted norms, recommended for pediatric patients. Options A, C, and D do not accurately reflect the rationale behind the shift to Z-scores in this population, as detailed in the Pediatric Bone Densitometry Guidelines. Question 30. At the heart of this issue is the understanding of the bone matrix composition and its impact on BMD measurements. Dr. Nguyen, an experienced bone densitometry specialist, is reviewing a case involving a patient with suspected metabolic bone disease. The patient's bone matrix composition, consisting of both organic, mainly collagen, and inorganic, primarily hydroxyapatite components, is integral to maintaining structural integrity. An imbalance in these components may be reflected in DSA measurements due to the alter X-ray attenuation properties. In this context, correctly interpreting how each component contributes to overall bone density is crucial for accurate diagnosis. Which of the following best explains the significance of bone matrix composition in relation to DSA measurements? A. The organic matrix has no impact. OMD DAK only measures inorganic minerals. B. Both the organic and inorganic components affect X-ray attenuation, but the inorganic hydroxyapatite is the primary contributor to measured BMD. C. The organic matrix is solely responsible for bone flexibility, which directly determines BMD values. D. Only variations in the organic matrix affect the T-score, while the inorganic matrix influences the Z-score. Answer. Correct answer. B. Explanation. Bone mineral density, BMD, measured by DAK reflects the combined contributions of both the organic matrix, mostly type I collagen, and the inorganic mineral hydroxyapatite. However, the inorganic component is the primary factor affecting X-ray attenuation and therefore largely determines the BMD reading. The organic matrix confers tensile strength and flexibility but does not contribute heavily to the densitometric measurement. This understanding is essential in interpreting DAK results and is thoroughly discussed in the composition of bone matrix sections of the ASRT bone densitometry curriculum. Options C and D misrepresent the contributions of these matrix components.